So as I was saying before, a joint stiffness is a iatrogenic lesion because the patient can always tell you or say to you, listen, doctor, I came with a broken bone or I came with an injury in my hand, but I never came to you with a joint stiffness. The joint stiffness is because of your treatment. And I don't think this is something that I deserve. So this is very important to know that the joint stiffness should never occur when treating a hand injury, unless there is an injury to the joint. So in order to talk about this, we'll talk about the etiopathogenesis, and we'll talk about positions of joint immobilization. We will not be talking about surgical treatment, just a couple of words. But how can we prevent a joint stiffness? Avoiding tissue edema, decreasing inflammation. Inflammation cannot be avoided because we need inflammation for the repair of the lesion, but just at the minimum, just to have some inflammation. Immobilization of the joints in the proper position, the short period of time, and the most important of all is avoid pain. To avoid edema is very easy. If the hand is at rest, it should be always elevated above the axillary level to prevent edema of the hand. So you should never use slings because a sling will put the hand below the heart level. And the liquids, the blood has to go to the axilla and then to the heart. So this is as bad as having the hand down like this. So never use slings. Always the hand should be above the heart level, over the head, sitting on a table, resting the elbow on the table, and when you're in bed, on top of a pillow. The hand, if it moves, it never swells up, same as the feet, because the pumping of the blood comes from the muscle contraction. That's why when you walk, your feet never swell up, but they will swell up if you take off your shoes and you sit down on an airplane, for example, for a long period of time. So the hand should, when it's not moving because of a lesion, should be always elevated over the axillary level. You can use a Coven bandage for the fingers because they are circular structures, and you can even use it in the entire hand. But it's quite practical to use it in the fingers because they allow mobility of the fingers. But the next question is, why do joints become stiff? This is a joint, the bone, the cartilage, and another bone. This is the MP joint, and in red is the capsule. The capsule, the joint is in a mid position between extension and flexion, and the capsule is like redundant, dorsal and volar. So how can you get a stiff joint from capsular shrinkage? But this will take a long time. And usually many joints, they become stiff in a matter of a few weeks, and sometimes even a few days. So really, the joints that become stiff in our practice is from collagen deposition. Collagen deposition over the capsule. And I would like to, okay, now. And the second thing is to decrease the inflammation, because the inflammation causes fibrosis. And we all know that the joints surrounded by inflammation become stiffer in a shorter period of time. For example, if we have a supracondylar fracture in one elbow and the other one, it's normal, has no injuries, and we immobilize both elbows for, let's say, a month, which one will become stiff? The one that had the supracondylar fracture. So it's not remodeling or shrinking of the capsule. It's because the collagen fibers have deposited over the capsule that has been shortened. Well, not shortened, but folded, really, I should say. And who is responsible of this? The fibroblasts. Oops, sorry. The fibroblasts. This is a microphotography of fibroblasts, which are releasing collagen fibers on one end of the fibroblast here in blue. And this is the fibroblast seen from this side, from this end, and we can see all the protocollagen fibers leaving the cell and going to the extracellular space. And here it's an electronic microscopy of a fibroblast. Here's the nucleus, and here's the reticular system. And the reticular system throws into the intercellular space protocollagen fibers. Here's some fibers cut longitudinally, like here in this section, and some other fibers are cut transversely, and we see them as little dots. And this is the Golgi apparatus that will secrete mucous material. So how can we decrease inflammation? Because inflammation, as we said, is one of the main causes of the joint stiffness. Minimizing the surgical trauma when you do trauma, and if it's an injury, you cannot minimize it, it just happened, but then you have to administer steroids to decrease the amount of inflammation. Steroids, what they do is they close these little poros that this is a capillary, and this is the poros. And if we put some dexamethasone here, or we can put many pharmaceutical agents, we'll see that the steroids close these pores and decrease inflammation, and decrease edema, and decrease the migration of fibroblasts into the tissues. So it's quite important when you do have a trauma or when you do surgery to provide, to give a patient steroids. And then immobilize the joint in the correct position. After you avoided the edema and you decrease inflammation, you cannot avoid it completely, but at least decrease it. But you have to immobilize it, the joint in the correct position. The hand can, at rest, can adopt two positions. The rest position, when it's doing nothing, in the traumatic position, when it's after injury. The rest of the time, the hand is doing things and it's moving. But these are the only two positions that the hand can adopt when not doing anything. In the positions of mobilization, there are two. One is the functional position, and the other one is the protective position. The position of rest, described by Frederick Wood Jones, is the one in which all the fingers are flexed, mainly the PAP joints, not so much the MP joints. And this is the position that he thought the hand should be immobilized. That was many years ago, because he thought there was a position will be more comfortable for the patient to be immobilized. Traumatic position is the one that we should always avoid. This is the worst one. The forearm is in pronation. The wrist is flexed because the weight of the hand, and MP joints are in extension because of tenodesis of the extensor tendons. When we flex the wrist, the MP joints go into extension, and also the edema in the back of the hand pulls the skin and brings the MP joints in extension. And when the MP joints are in extension, the PAP joints or the IP joints, they flex even more. So this is the position that we should always avoid, the traumatic position. In 1924, Sterling Bunnell, in that time there was no journal of hand surgery, but was the SGNO, because the surgeons at that time used to do surgery, gynecology and obstetrics, and he was a general surgeon, Sterling Bunnell, and he said that we should immobilize the hand in the functionating positions. That is, well, you can read it. I don't need to read it to you. And then this position was popularized by Alan Canaveral and Mason, and by other doctors practicing in Chicago, because they wrote a book on infections of the hand. It was the first book written precisely on hand surgery, and they could see many, I don't know, I would like to close this here now, okay. And sorry. And they called it the position of function, which is Sterling Bonnell called it the functionating position. But the functional position is the position of arthrodesis, is the position of permanent immobilization. This means that if you have a joint that is going to become stiff, you should put it in the functional position. But if you want it not to become stiff, you just want to immobilize it temporarily, you should put it into the safe position. It's a name used by J.A.P. James in 1970. The protective positions that Bob Beasley and we quoted in 1972, or if you want, you can call it the intrinsic plus position, because that's the position in which the hand should be immobilized if you want not to be stiff, which means that the MP joints should be flexed and the IP joint should be extended. In the protective position, in order of importance, is the AP joints. They should always be in full extension, not in 5 degrees of flexion or 20 degrees of flexion, because it will become stiff in 5 or 20 degrees of flexion. Should be exactly at 0 degrees, should be in full extension. And this is the most important thing, because the IP joint is the stiff joint that it's most difficult to treat, and you don't want to have a stiffness of the PAP joints. Then the MP joints, they are coming next in importance. They should be immobilized in flexion, but the treatment of an MP joint in extension is quite easy. So it's important, but not so important. Then antepulsion of the thumb. The thumb should be also separated from the index finger. And also the carpal-metacarpal joints of the ring and the small fingers should be flexed. This is a cross-section of the level of the metacarpals. This is the thumb, index, middle, ring, and the small finger. And this is a flat position of the hand, and the hand should be mobilized in this position. So the thumb should be abducted, and the carpal-metacarpal joints of the ring and small fingers should be flexed, because they flex normally. And for normal use of the hand, when you use a screwdriver, hammer, or many other things, we need to flex these two joints. And if these joints become stiff in extension, the carpal-metacarpal joints of these two fingers, the patient will have difficulties in touching the small finger to the thumb. And we might think that he has a thumb stiffness, but no, it's not the thumb. The thumb can do the operation quite well. The problem is he cannot flex and supinate the small finger in this case. So now let's go for the anatomy. What's the explanation? What's the rationale for this position of joint immobilization? First, we'll look at the metacarpal phalangeal joints. Here on the left, we see the metacarpal. In black, the origin of the collateral ligament. Here, the proximal phalange. And here, the insertion of the collateral ligament. As we can see, goes from the dorsum of the metacarpal to the base of the proximal phalange. If we make a drawing of the metacarpal head from the center of rotation of the collateral ligament, the origin of the metacarpal head, we'll see that the distance from the origin of the ligament to the dorsal part of the joint is much smaller than when it is in the volar part. So there is a big difference, 5 millimeters in the dorsal and 10 millimeters when it goes volar. And this explains why the collateral ligaments are lax in extension and they are tight in flexion. In extension, we can move the fingers in radial inclination and ulnar inclination, but we cannot do this when they are in flexion. And here we can see quite well, this is the metacarpal head, the origin of the collateral ligament on the most dorsal part of the metacarpal head. Here I cut the ligament from the insertion into the proximal phalange. And in the proximal phalange, which is this is the base, the articular surface of the proximal phalange, I did the reverse. I cut the collateral ligament from the metacarpal. So we can see that the collateral ligament inserts in the most volar part of the proximal phalange. And if we hyperextend the joint, we'll see that the collateral ligament not only inserts on the most volar part of the proximal phalange, it really inserts underneath the proximal phalange. And why is that? This is to protect the proximal phalange to subluxate volarly from the force of the flexor tendons, intrinsic and extrinsic extensor tendons. Another reason why the ligaments get tighter, collateral ligaments in flexion, the inflection is because the shape of the metacarpal head. Metacarpal head, it's wider at the bottom and the volar side than in the dorsal side. And this puts the collateral ligaments into even more attention. So we should try to immobilize these joints always in full flexion, 90 degrees of flexion. But there is a little bit of tolerance because to immobilize the MP joint in full flexion is a little bit difficult for the surgeon to put a bandage, etc. Here we can see an example of a stiff MP joint, in which I did a dissection. The collateral ligament, it seems to be normal, but if we try to flex the joint, this collateral ligament, this is from a hand that was stiff, and I did the dissection afterwards to see what happened to the ligaments, and I could see that the joint could be flexed maybe 45 degrees, 40 degrees, but it opened like a book. It was not a gliding of the joint surface. And I could even flex it because the patient, well, it was not the patient, unfortunately, it was a cadaver. But here we can see that there was no gliding of the articular surfaces. But when I cut the collateral ligament, then I could put the joint in congruity with the head of the metacarpal. Okay, so we know that the collateral ligament, it's loose in extension, and we don't want to immobilize it in extension because we will have the position of collagen fibers into the collateral ligament and we will never be able to stretch it. But what about the volar capsule? This is an MP joint. This is the volar capsule of the MP joint. In the MP joint, well, here metacarpophalangeal joint, the flexor tendon sheath starts right here, inserts in the volar plate. And the volar plate is not inserted into the metacarpal as compared to the PAP joint. In the PAP joint, the volar plate is inserted into the proximal phalange. And that's why we cannot do a hyperextension of the PAP joint, but we can hyperextend the MP joints because the volar plate is not attached proximally. And another reason that we will never have a problem with the MP joint and with the volar plate with the MP joint flex is that the flexor tendons will pull it away from the metacarpal. It will be an interposition of muscle. So you will never get a fibrosis of the proximal part of the volar plate, as we will see in a few minutes on the PAP joints. You all know that the metacarpophalangeal joints will never become stiff in flexion. So always should be immobilized in flexion. You might have a duplitrans contracture, like in this finger. I'm trying to straighten the finger, and I cannot straighten it because there is a retraction of the palmar fascia. And here I will never, or you will never have to do any surgery into the MP joint, regardless of how long the joint has been in flexion. The only thing to need is to remove the structures that they cause the contracture of the joint, which is removing the fascia and a Z-plasty lengthening of the skin, because with time, the skin remodels also and needs to be lengthened at the base of the finger, and in this case, at the level of the transverse palmar crease. So I think it's quite clear the MP joint should be mobilized in full flexion. What about the PAP joints? The PAP joints are trochlear. The MP joints, they are condyles, and they can move flexion, extension, radial inclination, ulnar inclination, and even rotation. Rotation means supination and pronation. The PAP joints are trochlear, and they have two condyles. This is from the dorsal part, one condyle here and the other condyles here. Then we can see them better probably from a volar view, because here's the retrocondylar space. And these joints are very stable. They have good lateral stability. And why? One reason is bone morphology, because they are much wider than they're quite wide, and they have a bicondylar shape. And also because they have very thick collateral ligaments. Collateral ligaments in these joints are incredibly thick because we don't have intrinsic muscles like in the MP joints. The MP joints, we can stabilize them with intrinsic muscles, but the PAP joints, we don't have muscles to stabilize them. So we need strong ligaments. But even these ligaments, they can be broken from injuries, and you can have broken ligaments, but you don't need to repair them because the bone morphology provides stability. You can have a joint ligament injury in any other joint, and the joint will become stiff, but not in the PAP joint. You don't need to repair them. The joint needs to be mobile. You need to move the joint. And if you want to immobilize it, for whatever reason, it should be immobilized in full extension. And now we'll see why they have to be immobilized in full extension. This is just to show you how thick the collateral ligaments. The knuckles here, if you touch your finger, they are really thick, but the bone is much smaller. So all this space is occupied by the collateral ligaments. The collateral ligaments in the PAP joint, this is the proximal phalanx, here the middle phalanx. Collateral ligaments here are true collateral ligaments. They originate at the center of rotation of the head of the proximal phalanx, and they insert practically at the center of the middle phalanx, just a little bit anteriorly for the same reason, to control and prevent volar subluxation. But as you can see here, the condyle of the proximal phalanx is completely circumferential, not like in the metacarpal head, which was the distance was the radius of curvature was smaller here and was larger volarly. So this means that the collateral ligament will always have the same length in extension here or in flexion. In the PAP joint, you can check in your fingers. In your fingers, the PAP joint, it's always stable in extension, mid-flexion, or full flexion. So from this, we can deduct that the collateral ligament is not the cause of a joint stiffness, as opposite to the MP joints. The problem here at the PAP joint is the volar plate. This is a proximal phalange, distal middle phalange, collateral ligaments from the center rotation of the proximal phalange to the practically center, but a little bit anterior part of the middle phalange, and this is the volar plate. And here we can see what happens to the volar plate when we flex the PAP joint. The collateral ligament doesn't change in length, but the volar plate changes and falls upon itself. And here I remove, this is the A2 pulley, this is the volar part of the finger, volar part of the finger. This is the end of the A2 pulley. This is the A4 pulley distally, and here is the volar plate. All this is the volar plate. And this is the A3 pulley, A2, A3, and A4. The A3 pulley inserts on both sides of the distal part of the volar plate here. By flexing the finger, we can see the flexor tendon protruding proximally. And here the vincula coming from the digital artery to the flexor tendons. And now we'll see in more detail the volar plate, or the volar plate capsule, I should say. The volar capsule, this is the volar part of the finger. Here we have proximally on the left the A2 pulley, and here the A4 pulley. And the volar capsule is formed by a thick distal part, dark green. This is the distal part of the volar plate, which is a fibrous tissue, really thick. And then there is a membranous proximal part, which I think the right name is an arcuate ligament, because it makes like an arch. And this arcuate ligament is the one that flexes when we flex the PAP joint. And why do we have an arcuate ligament? To let the vessel coming from the digital artery to form the vincula to the flexor tendons, the sublimis and the profundus. And here we can see the volar plate, the thick part distal, right here below in contact with the bone, and the arcuate ligament proximally. And this is the artery coming from the digital artery. And here another picture showing the distal part of the volar plate, the A3 pulley, the A2 pulley, and the A4 pulley. And this is the membranous part of the volar plate, which is, I think it should be called the arcuate ligament, because it inserts to one side of the proximal phalange and to the other side of the proximal phalange. It makes like an arch in between. And here we can see a joint, an X-ray in full extension and in full flexion. As you can see, the distance is exactly the same in flexion and in extension. So the collateral ligaments, they never change in length in the PAP joint. What happens is the membranous part, the arcuate ligament that falls on itself. This point, this dot here, we think, corresponds to this one in full extension. And when we flex the joint, this dot is here, when it should be here. And if we keep this joint immobilized in this position for a long time, mainly if there is a fibrosis in this area, if there is an injury. For example, if there is an injury to the PAP joint, it will become stiff in 10 days. If there is an injury to the wrist, it will take much longer, because will be less fibrous tissue deposition in this area. The fibrous tissue deposition will also occur in the flexor tendon sheath and the skin that we'll see in a moment. The flexor tendon sheath is another cause of stiffness in flexion of the PAP joints. As you know, there are annular pulleys, A's, and cruciform pulleys, C's. The A1 in the volar plate, A3 in the volar plate, and A5 in the volar plate, and the odd numbers are in the bones, A2 and A4. In the cruciform pulleys are proximal and distal to the joint, to the PAP joint, to allow the flexor tendon sheath to fold on itself. And in the DAP joint, there is only one proximally, because there is not a space to have one distally. This is the flexor tendon sheath, in which you put a little dot of ink in full extension of the joint. And when it's put in the inflection, we can see that all the dots, they become much closer together, mainly at this point between the A2 and the A4 pulley. So everything gets crumbled right here, between the C1 pulley right here, the A3 pulley, and also a little bit in the C2 pulley. What about the skin? This is the last structure that we should look. The skin in the dorsum, this is the nail, this is the dorsum of the finger, the skin is cut here, and it's lifted towards the other side. And we can see that at the dorsum of the PAP joint, the skin is very thin, it's almost transparent. So this should not be a cause of stiffness of the joint if we mobilize it in extension, because the skin here, it's very thin. And the only other structure that we have here is the extensor tendon. The extensor tendon, it's a mobile structure that moves proximally and distally, but it doesn't fold upon itself. But look what happens to the volar skin. And we saw before what happened to the arcuate ligament. First, the distance is much larger from the center of rotation of the PAP joint to the volar side than to the dorsal side. So this means that the skin has to fold, has to shorten much more volarly than dorsally if it's an extension. And we can see here that the skin, when the PAP joint flexes, it folds, making like a T. You see, it makes like a T because it doesn't move. The skin can move in many parts of the body, but not the palmar skin or the volar skin of the finger. So all the following structures can be shortened from volar to dorsal. In the skin, as we mentioned before, the capsule by volar plate and collateral accessory ligaments, the retinacular ligaments of Landsmeer, the transverse in the oblique, and the skin retaining ligaments that we'll talk about now. The Cleland described many years ago on the cutaneous ligaments of the phalanges, because they go from the skin to the phalange, to the bone. And this is a drawing from his publication. It goes from the skin to the bone. Here's the flexor tendon sheath, not very well detailed, but we can see that it does not go to the flexor tendon sheath, it goes to the bone. And then a few years later, Grayson, with more detail, studied saw another ligament, which is called the Grayson ligament. This is the Cleland's ligaments that we saw before. They go from the skin to the phalange, to the bone, and they are dorsal to the nerve and to the artery. The artery is dorsal to the nerve. And the Grayson ligament goes from the skin to the flexor tendon sheath. And what's the purpose of these ligaments? To stabilize the skin in the finger. So if we grab one finger with the other hand and try to roll the skin around, we will not be able to roll the skin, but we can be able to roll the skin in the forearm, in the thigh, or in the leg, in many other places. And this is the purpose of the retaining ligaments of the fingers. If we have one finger, this is my finger, you put a dot of ink here at the where the fold starts, the folding of the skin starts. All the skin is hidden here inside. Here the DAP joint, here the PAP joint. We start straight extending the finger, and if we put the finger in full extension, we'll have the shape of this completely straight line a few seconds ago. And this is because of the skin retaining ligaments. Skin retaining ligaments, mainly Cleland's ligament, which is the inserts mainly around the PAP and to a lesser degree at the DAP joint. So the PIP joints never become stiff in extension from a capsular pathology, never, because the capsule is very thin, the extensor tendon is mobile, and it will never become stiff in extension. So you should never be afraid to immobilize the joint in full extension. If you have a limitation of flexion or stiffness in flexion of the PIP joint, it will always be due to problems with the extensor apparatus, always, not from a joint problem, not from the capsule or from the skin, either from adhesions of the extensor apparatus in the proximal phalange or a fibrosis of the intrinsic muscles. A fibrosis and retraction of the intrinsic muscles will prevent the PIP joint to flex because they cause extension of the PIP joint. So if after trauma we see a patient that has been immobilized that cannot fully flex the PIP joint, most probably he has an intrinsic muscle contracture. So check for intrinsic muscles and put the MP joint in full extension, and you will see that the patient will have even more difficulties to flex the PIP joint. So it's quite common after trauma to see a certain degrees or loss of elasticity of the intrinsic muscles. And to finish, for the treatment, I will be very brief, and I will say that we should remove everything which is anterior to the axis of rotation of the joint. So we should preserve the collateral ligaments, but we should remove the accessory collateral ligament. The accessory collateral ligament is the one that goes from the proximal phalange to the volar plate, to the thick part of the volar plate. We should remove the volar plate, the thick part, and we should remove the arcuate ligament. And also we should remove the Cleland ligament, dorsal, and Grayson's ligament, volar. And we should leave only the collateral ligaments, the flexor tendons, sublimis and profundus, the artery dorsal, and the nerve volar, because these are structures that they are mobile. But the rest of the structures that may have a deposition of collagen in the surface, it should be removed. And it's very important to remove these ligaments, Cleland and Grayson, mainly in cases of Dupuytren's contracture. Because if you want to treat a PIP joint stiffness in a Dupuytren's contracture, these ligaments are pathologically thickened. So you should remove these ligaments, and you do the surgery from the anterior side, obviously, until you see the nerve, the artery, and even the skin, the subcutaneous tissue of the dorsal skin of the PIP joint. We all know that the dorsal skin on the hand and the fingers also is thinner and mobile. So we can pull it like here, vertically, we can move it to the radial side, and we can move it to the ulnar side. But it's not elastic. It's not elastic at all. The skin is not elastic, neither longitudinally nor transversely. He put some dots of ink, and you can see that they're not separated either transversely or longitudinally. What happens is that the skin can retract and stretch. And that's what happens. That's all mothers, they know, that when they get pregnant, the skin retracts, stretches, and then retracts. And Why does the PAP joint flex when you extend the MP joint? Well, could be one of these three explanations. Tenodesis of intrinsic muscles? No, because when you put the MP joint in extension, you put even more attention into the intrinsic muscles, and this joint will not flex because of the intrinsic muscles. Tenodesis of extrinsic flexors? No, because you can flex the wrist with the finger in this position, and the MP joint will continue in extension, and the PAP joint will continue in flexion. So what's the cause of the PAP joint to flex when the MP joint is extended? Because of dermatitis. And what does this thing mean? That the skin in the volar side of the fingers doesn't glide proximally and distally. It falls on itself. As it showed in the other places, there are no skin creases, but in the volar skin, there are skin creases. So this explains why sometimes if you see a patient like this with a flexion contracture of 30 degrees of the PAP joint, or this other case with a flexion contracture a little bit more important of close to 70 degrees, you will not see this crease of the skin. You will not see this because the skin has remodeled, and the skin remodels, as you remember, with the pregnant women. And this is the reason, and this is the thing that I learned the latest when I treat PAP joint flexion contractures, is the shortening of the skin. It's something I learned about 10 years ago after treating a very nice woman in which I got full extension of the PAP joint at surgery, and she was wearing a splint during the night, and she came to my office telling me, well, the finger goes back into flexion, doctor, what happened? And then I examined the finger, and the PAP joint I could extend, but it took me a while to realize that it could extend when it was flexing the MP joint to release and get more skin to extend the PAP joint. And this is what happens to many patients. Yes, doctor, I put the splint at nighttime and the finger is straight, but then during the day it keeps flexing. Why does it keep flexing? Because the patient needs to extend the finger at the level of the MP joint, the entire finger. And when they extend it at the level of the MP joint, since the skin is shortened, then pulls the PAP joint into flexion. And the more extension you make to the MP joint, the more flexion you get into the PAP joint. And since the skin has never been released, you will have again another flexion contracture of the PAP joint. So we recommend you from now on to measure the distance of the creases, the center of the crease, because there are two creases in this joint, the center of the crease at the base of the finger, PAP joint and the AP joint, and measure the skin in the normal finger, and then measure it again in the finger that has a flexion contraction. And you will see that there is a big difference. Usually minimum 3 millimeters, but they have found up to 13 millimeters of skin length difference. So it's very important not to think only about the capsule and the flexion tendon sheath, but think about the skin. Where can we lengthen the skin? If we have a camptodactyly, and this is quite obvious, it's a camptodactyly because of the deformity of the bone, we have a lot of skin here. And then we can do a C-plasty over the PAP joint, as we see here, and then do a joint release and should be no problem. But if you have an injury or a normal finger, it's very difficult to do Z-plasty at the level of the PAP joint. Why? Because if you want to gain length of the skin, because they are lengthening Z-plasties, you have to get skin from the sides. You cannot do magics. You have to, if you want to gain longitudinally, you have to get it from the sides. That's why you should never do a Z-plasty at the DAP joint, because there is not enough skin from the sides, and it's very difficult at the PAP joint. Here I did it because there was a a slight retraction of the skin, and it is a C-plasty. But the C-plasty, when you do PAP joint release, should always be done at the base of the finger. So you do the surgery here, you continue the incision, and always do a Z-plasty here, because you can gain a lot of skin from the side of the finger, and you can really lengthen up to 13 millimeters. And finally, what about the wrist? We didn't say anything the wrist. How should we mobilize the wrist? Well, however it's needed, because the wrist is a joker. This is not a real position in which the wrist will become stiff. You can immobilize it in extension, neutral position, or flexion. And you put it into the position that it's best to put at rest structures that have been repaired, like nerves or tendons, etc. So the wrist doesn't become stiff in any particular position. So as a resume, the joint stiffness will come mainly from inflammation, also from edema, because it causes dorsal skin distension, and also from the immobilization in the traumatic position. And then you will become a joint stiffness. But it's very important, pain. Pain is the worst thing that you can have. If you have an injury to the PAP joint, sprain in the joint, and the patient can move the joint and doesn't hurt, no problem. But if this joint, even a small sprain, this joint is painful, this joint will become stiff with the passing of time. You can have a neuropathic joint, a Charcot joint, for example, of the knee that we don't see now anymore, but it's never stiff, a Charcot joint, regardless of how destroyed it is, because it has no pain. But if you have a patient that has pain in a PAP joint, treat the pain, immobilize it, and don't do anything until the pain has disappeared. So never perform surgery on the interphalangeal joints if they are painful. You can do a bone scan if there is a Sudex neurovascular dystrophy, or just touch the joints, pressing on both sides, radial and ulnar, and as the patient, they have pain by touching the joints, not dorsal and volar, but radial and ulnar side. And when they don't have pain, then you can do the surgery. If you want to go faster, you tell the patient, listen, I'm going to immobilize the joint, but doctor, I have a stiff joint. You're not going to immobilize it. Yes, because I want to get rid of the pain. And I will immobilize it either with a full plaster, if it's a several joint involved, or with a finger splint, if there is only one finger involved. And only when there is no pain, then you can do surgery. And the results will be good if the surgery is done meticulously. Thank you for your attention.